Hello, everyone, and welcome back. We are about to start our PMHNP crash course review. Okay, it is super important that you write it down every single line. It's important that you write it down every single example. In fact, on this module, we are not providing you with a PDF. Why? Well, if you watch our module one, right, writing down, reading, it works your right side of your brain or right hemispheres, which is also is the part of the clock drawing test, right? The right hemisphere, the right brain, the parietal, right? So by writing down, I want you to organize this information in a way that makes sense for you. Okay, and this information will make sense in different way for different people. So every slide, please pause and write it down. There is an example that's important. You need to know there is anything, whether it's highlighted or not, it's important. You see different highlight colors. It doesn't mean one thing is more important than another. I just want to call your attention to different things by having different colors. So it breaks the monotony here. Okay, every single thing is important. I'm repeating it. Please do it. Write it down. Write it down. Write it down. You need to master every single line on these presentations for this course because some of you might depend only on this course. So let's go. Let's ace this PMHNP board certification. My name is Dr. Lopez, and I can't wait to see you become board certified. Okay, we're about to start, and as usual, we'll put out a roadmap. On this specific training, module 2, we'll be covering the thyroid stimulating hormones, we'll be covering Depakote, Kava, Lamictal, antipsychotics, carbamazepine, lithium, neuroleptic malignant syndrome, serotonin syndrome, antidepressants, a psychotics condition that can increase suicidality. As you know, safety is super important. Schizophrenia, the MSE and the MMSE, which is also known as the Faustin test, which, by the way, you need to know, the clock drawing test, and the dopamine pathway. So, starting with the TSH level, you need to know the TSH level. In fact, some books may have a different reference, but for sure, our nursing book, also known as the Purple Book, had this information incorrect. The correct values for the TSH is zero point 0.5 to 5.0. You need to know these values. Equally important, when someone has symptoms of hyperthyroidism, they mimic mania or anxiety symptoms, right? They'll be agitated. Once someone has symptoms of hypothyroidism, it is equivalent to symptoms of depression. And we'll go through those symptoms in detail. I just want to give you a highlight here. Now, you begin by checking the TSH levels when you want to find out if someone is hyper or hypothyroidism. You check the TSH levels. For example, if the TSH secretion decreases, meaning is low, then you look at the T4, T3, and that should be going up. If you have this inverse relationship in which the TSH is low and the T4, 3T is high, that indicates hyperthyroidism. And hyperterrorism looks like something heat intolerance, agitation, anxiety, irritability, tachycardia, mood swing, and weight loss. Even though they eat a lot, they're burning through calories, yet they may have a very thin body. So one example here, if the TSH is low, zero point 0.4. Remember, the regular value is zero point 0.5 to 5. So if the TSH is low, zero point 0.4, then you examine the T3, T4, which should be high. That way, you know this is hyperthyroidism and the symptoms are close to anxiety mania. Another example, if you look at the TSH and it is high, you will look at the T4, T3, which are low. Inverse relationship. then you know this is hypothyroidism, which mimics symptoms of depression, such as cold intolerance, not so much, but is a cold intolerance, lethargy, weight gain, even though they may not eating a whole lot, decreased libido. An example here, when the TSH is high, it's zero point 0.6, and the T334 is low, at low levels, right? So this is important. You only need to memorize the TSH levels, look at it, and see if they are in inverse relationship. If they are, then you assign the TSH level to the T334, and then you should get this question right, whether it is hypothyroidism or hyper. Again, you need to know the symptoms of hyperthyroidism and the symptoms of a hypothyroidism. Write it down every single line, guys. Okay, as we move on, let's talk about Depakote, right? As I mentioned before, you don't need to know a whole lot, but you need to know what's specific about a specific medication. For example, black box warning. Depakote has a black box warning for liver toxicity and pancreatitis. Liver toxicity and pancreatitis. So intervention for any medication when the reached toxicity level is to discontinue the offending agent. Let's say, for example, the question says the patient is doing well, but has, whatever symptoms is severe, then that's a cue to you that to discontinue anytime the symptoms are severe. It doesn't matter which medication. If it says severe, it's a cue that it is out of the range. Here, your action, if you examine toxicity levels, is to discontinue the medication. Well, how do you know if it's toxicity level? Well, we know that the offending agent, the TSH, the AST and the ALT is an indirect measurements for liver damage. So when you look at the AST, you have 5 to 40. When you look at the ALT, you have 5 to 35. So it's a 5 points difference. Okay. You may know that there is a liver toxicity when these levels are high, right? Outside the range. Now, what is the range for Depakote? 50 to 125. That's a normal range. That's where you want to be at. If the toxicity level may present when the levels of Depakote is above 150. And what those symptoms look like, you might find patients that are disoriented, lethargic, respiratory depression, nausea, and vomiting. Disorientation, lethargic, respiratory infection, nausea, and vomiting. Well, what are you to do? Yes, you are to discontinue the medication, offending agent, and conduct a liver test. But first, you discontinue. If option A is to discontinue and B option is to check the liver levels, then you discontinue first. When you're checking for toxicity level for Depakote, you need to check the liver levels and ammonia levels. So Depakote, liver levels, and ammonia levels. Now let's talk about the symptoms of liver toxicity, followed by the symptoms of a pancreatitis, which we mentioned. These are the two black box warning. So with liver toxicity, you'd find abdominal pain, right? Usually in the upper right corner quadrant, reddish brown urine, yellowing of the skin, and white of the eyes, and fatigue. That's your liver toxicity. Well, what pancreatitis symptoms look like? That's an emergency too, right? So abdominal pain, pain radiating to the back, fever, rapid pulse, nausea and vomiting, and oily stools. So here are the important things that you need to know. But let's now talk about OB patients. And if someone, especially on the first time trimester, and they are taking Depakote, your first action, if everything is going to okay, is to ask for a pregnancy test. Wonder why? Well, because of the risk of neurotube defect. Okay, so your first action, if someone is pregnant, is to ask for a pregnancy test because you are assessing, right? When you're collecting for a lab, when you're collecting vitals, that's your assessment, okay? And here you are trying to prevent neurotube defect and DEPA code. Did you see how much information is on DEPA code? Right? It's just one slide, but every single line of those is important. So you really, really need to know every single line that is on this presentation, okay? So this presentation is packed with information that you need to know. Please do not skip it. If it's not highlighted, don't think it's not important because actually it is. If I'm going to highlight every single thing here, then nothing becomes important. Okay? But you need to know the levels of Depakote. You need to know when you have toxicity of Depakote. Depakote, you need to know when there's liver toxicity, which is different than Depakote toxicity, and you need to know what are the symptoms for pancreatitis. Okay, I will not hop on this anymore, but every single thing is super important. Kava, right? Kava is a herbal supplement, and guess what? It also affects your liver, right? It's used for anxiety, stress, and insomnia. Kava can potentially cause liver damage. Therefore, the priority action is to stop the medication. And if there is not one of the options to stop the medication, if you suspect toxicity, you may want to collect the labs at first, right? If the option to stop medication is not present, then your first action when you see kava is to do a LFT. First actions do a LFT. Now, it's important to know that kava interacts with a lot of medications, right? So kava, since it's given for anxiety symptoms, right? You want to calm someone down, you may want to avoid kava with any medication that's indicated for anxiety, right? And that can be benzodiazepine. You don't give together with gas with GABA, right? Kava. Sorry. So it can cause excessive drowsiness as a side effect. Now, of course, again, it interacts with other things, and one of the things that it interacts is with people going to surgery. So in that case, you want to stop kava before the patient reports to surgery. Now, if options ask to collaborate with the surgeon, that may be a good option as well, right? Before you stop the kava. But here, let's move on to lamictal. When you hear lamictal, you are to think of Steven Johnson syndrome. And what Steven Johnson syndrome looks like fever, fever, body aches, peeling of the skin, facial and tongue swelling. So lamictal, Steven Johnson syndrome causes fever, body aches, peeling of the skin, facial and tongue swelling. So you need to know those sign symptoms. Now, Lamictal is a good medication for bipolar depression. It does not produce a great effect for the many symptoms, but is great for bipolar depression. And it also has one good characteristic. Lamictal is the least weight gaining of all mood stabilizers. So that's important, right? We patients often do not want to gain weight. They have a fear of gaining weight. So Lamictal can be a good choice. Now, for example, here, remember examples are important. So you pick this medication when the patient is at risk for metabolic syndrome. Well, if you are in one of my classes, I always say to add the mood stabilizer plus an SGA when you're dealing with mania. So if you're dealing with a patient, I'm sorry, um, when you're dealing with a schizophrenia patient, right? So if you need to have an SGA or second generation plus a mood stabilizer for people that have a symptomatic psychosis symptoms, right? You may want to add lamictal, okay? And to prevent metabolic syndrome, you may want to pick out of the mood stabilizer, you pick lamictal. All right, now let's move on to antipsychotics medication, right? So antipsychotics medications with the least weight gaining, you have ziprasidone, aripiprazole, and lurazidone. Some people call it Zal. If you want to call it this way, that's completely fine. It's easy to memorize. But no, if Lamictal was the least gaining weight gaining out of the mood stabilizers, for the antipsychotic, aripiprazole is the least sedating. The least weight gain is ziprasidone, aripiprazole, and lurazidone. Okay, so Abilify is the least sedating out of those. Now, anytime this is super super important. I actually did a chart review on a doctor yesterday, and I was like, well, man, you've been prescribing antipsychotics medications, and you have not been checking your BMI or either your hip to waist ratio. Hip to waist ratio. In fact, if questions ask which of the metabolic syndrome is the first to appear, the first to be abnormal, you wanted to pick hip to waist ratio. Also, what are the symptoms of a metabolic syndrome, right? So, glucose shoots to the roof, the lipopeno increases. So, you want to make sure that you're collecting those actions before you prescribe any antipsychotics, first generation or second generation, to ensure that you are following through with those measurements and see for change. Okay. So, and if you come across a patient that has changed, has gained weight, the hip to waist ratio has increased, what is your priority? And someone is stable, right? So, your priority, you may ask, well, someone is stable and doing super well. Finally, was able to stabilize the patient. What am I going to do? Okay, your first answer of what you're going to do, your priority is to provide um, counseling, exercise, and counseling. Right? You want to endorse aerobics, exercise, running, or walking, something along those lines. Then, if possible, someone's stable, you don't want to destabilize them. Then, if possible, you want to switch the medication. If offering counseling and exercise is not a choice in your task, then you want to consider ZAL, zip, zip, ziprasidone, aripiprazole, right? And Latuda or lurazidone. Okay, but the first action is to switch to exercise, offer exercise and counseling. Now, if example here, if the patients take Seroquel, right? Seroquel, the patient's taking Seroquel, your initial action is to first recommend exercise, then nutrition counseling or nutrition counseling, and then switch the medication, as I mentioned. And remember, Abilify is the least sedating, right? So again, guys, I'm not putting a whole lot. There is a lot of things that is missing on this presentation, but as you see, I am only covering the super duper important stuff. So everything is important here, okay? So let's move on. Now let's talk about carbamazepine. In practice, I don't see a lot of people using carbamazepine, right? Because it's complicated. It's a medication that interacts with a lot of medication. But there are two side effects that I'm mostly known for. In fact, they are the black box warning. Ting, 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 black box warning. Carbamazepine, you need to know agranulocytosis, which is the decrease of white blood counts, and aplastic anemia. When you hear aplastic anemia, think about bleeding, right? They're likely to bleed, but aplastic anemia produce pallor, fatigue, headache, fevers, nosebleed, bleeding from the gum, skin rash, and shortness of breath. You need to know those symptoms. Steven Johnson syndrome, right? When the question involves carbamazepine as one of the answer choice or lamictal, you should be worried about Stephen Jones syndrome. However, when the question is culturally sensitive, in this case for Asian population, and you have a choice between lamictal, Stephen Jones syndrome, and carbamazepine, both cause Stephen Jones syndrome, I need you to pick carbamazepine if the theme of the question involves Asian patient. If it doesn't, then you pick lamictal. Before you prescribe carbamazepine, you need to collect the HLA-B 1502, right? Which is you need to screen those are more sensitive for Stephen Jones syndrome while being prescribed lamictal. Now, there are two medications that also can cause agranulocytosis, and I group them here to make it easier for memorization: clozaril and carbamazepine. So, we said that agranulocytosis pose a risk for, well, it is a decrease in white blood count. So, you need to monitor for signs of infection, mainly fever. The patient is doing wonderful and all the signs has a fever, your action is to stop the medication. If the patient has a sore throat, you stop the medication, right? So your priority, anytime you see carbamazepine or chlorozaril and you have an infection, you stop the medication despite of the levels of ANC. Well, if the patient is doing well and the ANC level is 1500, however, now the patient has a sore throat and a fever and the runny nose, your action is not to continue the medication. Your action is to stop the medication because of the symptoms of possible infection, right? Now, if the questions only give you the A and C levels, and the A and C levels is less than 1000, then you stop the medication as well, right? Whether or not the patient's having signs or symptoms of infection. So both things to account here is the A1C, you stop below 1000, and if the patient has infection, you also stop the medication. Now, I want you to memorize this, that carbamazepine contains three A's, and that goes for your agranulocytosis, Asian predisposition for Stevens-Jones syndrome, and A for aplastic anemia. The three A's: agranulocytosis, Asian population, and A for aplastic anemia. You need to know. Heck yeah, you need to know this. So let's move on to lithium level. Know that your lithium level is zero point 0.6 to 1.2. Toxicity starts at 1.5. Well, what do I do if the lithium level is between 1.3 and 1.5? Well, you do monitor. You just monitor the symptoms unless the patient is symptomatic, and then you continue to collect your labs. You continue to assess the patient. You don't have to just stop the medication. You can continue to assess. Now, know that lithium is the gold standard for patients with bipolar disorder. Lithium is neuroprotective of choice for mood disorder. Mania can be can protect the nerves from damage, right? Seizures causes damage, mania causes damage. So we want to protect those patients with lithium, prevent them from becoming manic. So it's a gold standard, and anything that's a gold standard, we need to know. It also has something very specific. Lithium has evidence of anti-suicide effect on patients with bipolar mania-like symptoms. So, if the question asks you which of the following medication has anti-suicide effect, watch for the symptoms. Is the symptoms of mania? You pick lithium. If the symptom is of schizophrenia or psychosis, now guess what? You picking clozaril that has been shown to reduce the risk for suicidality in patients with schizophrenia symptoms. Okay, pay attention so you don't get tricked between clozaril and lithium. Now, lithium again, as you know, it's it's a complicated medication that has to do with kidneys. When you hear kidneys or when you hear lithium, think of it as the kidney medication. But you want to check your TSH level because lithium can cause hypothyroidism as a side effect. Now, because it's lithium and has to do a lot with sodium, you want to check the creatinine level, which is easy to memorize, zero point 0.6 to 1.2. You want to check the BUN, which is 10 to 20 to 20. Now, watch out because you may have a urine analysis. You may do a urine analysis checking for protein in the urine. And that can be something like large amounts may indicate kidney disease. So you want to monitor closely. So does it mean you have to stop a the lithium when the levels is of protein, urine protein of +4? Not necessarily, but you're now going to watch the patient more careful. So that means that there is a damage to the liver which could cause toxicity. It doesn't mean you have to stop, right? But you now monitor very, very close, maybe collecting labs more frequently and so forth. Again, priority action with lithium is to collect the HCG. And for patient population in the test scenario, anyone between 12 and 50 females is your priority action because lithium can cause cardiac malformations, including abstin anomaly. Okay, so question may ask you, uh, a patient comes to you with a murmur 2.5, they give you a description of a murmur and tells you lots of things and blah blah blah. So you may want to associate the symptoms of mania to the patient by asking, hey, did your mother have a lithium medication? Was your mother uh, during pregnancy, was she having symptoms of mania? Was she taking lithium? So that's a valid question because we know that the lithium can cause cardiac malformation to include abstin anomaly. Okay, so it's all part of the symptoms you need to check. So your priority action is always to check for pregnancy tests. Now, lithium side effect. As I mentioned, lithium can cause hypothyroidism, fine hand tremors. I just want you to kind of highlight this here because if it's fine hand tremors, is the patient telling you you cannot see. The moment you can see coarse tremors, it means that's no longer a side effect. Now it's into the severity level because you can see it. Now, lithium too can cause a macular papular rash, GI issues, T wave inversion. I see this on the tests all the time through schools, right? T wave, what kind of an EKG change it produces? A T wave inversion, polyuria and polydipsia, right? Diabetes insipidus, and leukocytosis, which is the increase in blood of a white blood count. Now, again, what symptoms can lithium cause to the fetus? Again, just repeating the same information I just said a second ago. Now, we mentioned severity, lithium toxicities. Now we're talking about the levels are above 1.5. So now you hear severe nausea, diarrhea, and vomiting, confusion or drowsiness, coarse hand tremor. The gait is patients are not able to walk properly. So the gait is abnormal, ataxia, and the priority level is not to check the kidney functions, but you want to, the priority, the first thing is to discontinue the medication and you want to check lithium levels. Now, what are the things that can increase lithium, right? So that ties a lot with safety. So anytime you have in the steam of the question the patient has a kidney disease, ting ting, you need to be warned about lithium levels. Drugs that use renal clearance and say they can double the amount of lithium levels. So NSAIDs doubles the amount of lithium. So is that something to be watch out for? Yeah. So hydrochlorothiazide, ACE inhibitors, which also used for cardiac failure. ACE inhibitors are used for cardiac failure. Lisinopril can cause an increase in lithium levels. So any drug that use renal clearance, for example, NSAID, hydrochlorothiazide, ACE inhibitor, stop. If you hear ACE inhibitor, know that it can cause cardiac. Is you need to be monitoring the patient for cardiac failure. Okay, so if someone's prescribed ACE inhibitor, medication that's used for cardiac failure, so you need to have a possible question of why the patient's ACE inhibitors, right? Lisinopril can also increase lithium levels. So all of these medications can increase lithium level. Now, here is a fact of life. If your patient is dehydrated, it can also cause the lithium level. So let's give an example. Someone is playing soccer a couple times a day or a couple times a week, or someone's going on a hike. Do you think that could cause dehydration? Yeah. So if you have someone that's dehydrated, your action is to educate the patient of the possibility of toxicity when dehydration can be the cause. Well, how does it happen? It's simple. The sodium balance can cause lithium level by decreased renal clearance level. So both, this may be a surprise to you, but both hypernatremia or high sodium levels and hyponatremia, low sodium levels, can increase lithium level in the blood by decreasing renal clearance levels. Mm, interesting, right? I'll bet some of you guys didn't know that hyper and hypo could cause increase of lithium level. Now, the question is, how so? How one increase of sodium and the other one is a decrease of sodium can cause the lithium level? Well, so check this out. So it's about physiology 101 here again, right? And we are testing for the PMHNP board certification, but it's important to know. Let's take a look on the case of hypernatremia. So lithium is primarily eliminated from the body by the kidney. In hypernatremia, what the body does is too much sodium, the body conserves water by reducing the urinary output because it wants to dilute the salt. Okay? So this decrease the urinary output also means less lithium is excreted, leading to its accumulation in the blood levels. Ah, hypernatremia can cause increased level. Well, how about hyponatremia? Similarly, hyponatremia, the body tries to dilute the sodium by excreting more water. However, this increase in urinary output is kind of fooled by the kidney because the lithium now is reabsorbed in the kidney as in the kidney increases along with the water reabsorption as a compensatory mechanism to prevent excessive sodium loss. So now the body is actually putting the sodium out and keeping the lithium level. Okay, this increases the absorption that leads to less lithium being excreted and thus higher lithium levels. So basically, to summarize here, the body will excrete the sodium and keep the lithium, now causing a hyper lithium level. Okay, so it's always important to understand and not memorize, so that way you can explain it. Now let's talk about NMS. NMS, so neuroleptic malignant syndrome. So the highlighted here is something that's peculiar or something that you only see or mostly see with NMS. So let's go over a little bit. So question that talks in NMS, ask yourself, was the patient recent taking antipsychotics? Right? Or was the patient recently in surgeries? So oftentimes the patient will be in surgeries and maybe after 2 weeks will have symptoms of NMS because of the medications used. So when you see NMS, think about extreme muscular rigidity, often called lead pipe or mutism. Now, because you have a lead pipe, the body is shaking and causes increase in CPK. Muscles break down, and that will be digested by the kidney, causing myoglobinuria. And then you would have a increase in white blood counts, which is leukocytosis, and an elevator LFT, right? So now the priority here is to DC the offending agent. Now, I want you to really look at the other two choices here. You have two medications commonly used in cases of neuroleptic malignant syndrome. So, how are you going to choose? If the question has neuroleptic malignant syndrome and the answer choice is discontinue the offending agent, that makes easy. So you pick that. If the answer choice is bromocriptine or dantrolene, you have to look at the stem of the question. Does it ask for a dopamine to agonist? Why agonist? Well, it was caused by antipsychotics, which is a dopamine antagonistic. So you want to give bromocriptine, which is a D2 agonist. So if the question asks for a D2 agonist, you give bromocriptine. But because this patient has muscle rigidity, lead pipe rigidity, the physician or the nurse practitioner may want to give something to relax the muscle relaxant. You give dantrolene. It kind of relaxes the muscle rigidity. So what's important is to discontinue the medication, the offending agent, and look at the stem of the question. Do you need a D2 agonist? You give bromocriptine. Do you need a something to relax the muscles? Then you give dantrolene. Please understand the difference because this might be important to you. Let's move on now to serotonin syndrome. So, why does it come right after neuroleptic malignant syndrome? Because the symptoms are very close to one another. So, the serotonin syndrome, you want to look for the things that are different from NMS. So, you don't see hyperflexia in NMS. You don't see seizure like movements like myoclonic jerk. You don't see cyproheptadine in NMS. So when the patient presents with hyperflexia, myoclonic jerk, you want to give a treatment of choice, which is discontinuing the offending agent. If that's not a choice, then look for uh, uh, cytocryptidine, cyprocryptidine, because it is a medication that's your antidote for serotonin overstimulation. Now, what you see on NMS and serotonin are hyperthermia. They are hot. You might want to provide a cooling blanket. Both of them have tachycardia. Both of them have diaphoresis, right? And outer level of conscious. So, what you need to know about these medications, not to get confused, is the highlighted portion here For NMS, extreme muscle rigidity, mutism, elevated CPK, myoglobin, elevated white blood counts, elevated LFTs, and you know if it's D2 agonist, bromocriptine, if you want to relax the muscle, you give dantrolene. Moving on to serotonin syndrome, you need to know that the myoclonic jerks, hyperflexor are very specific to serotonin syndrome. You want to discontinue the offending agent and give cyproheptadine. Okay, do not confuse because they will try to confuse you between those two medications. Now let's move on to antidepressants. So black box warning, ting ting, you need to know: increase suicidality or self-harm in children, adolescents, or younger adults. So usually it's age 23 and lower than, right? So your priority for self-harm and self-harming behaviors or younger adults that present with suicidal ideation after you given a antidepressant is to discontinue the medication. Well, let me give you an example. Let's say that you give a medication for someone that had a PHQ-9 score of 19. Well, 2 weeks later, the patient comes back and say, "Hey, takes the PHQ-9. Now the score is 3." You'd be like, "Great, doing great." Yeah, and the patient says, "Hey, I feel more relaxed. I'm actually doing good." But I want to point out to you that I start having suicidal thoughts. Then you go, "Okay, what is your action? Is it to increase the medication, decrease the medication, switch to the medication, or discontinue the medication?" So your action is to discontinue the medication regardless of how the patient's symptoms are presented. Why? Safety first. Patient has suicidality, and it's caused a by you giving the uh, antidepressant medication. So your action, despite of how beautiful the test makers may present to you, that the patient has a gotten better, in short amount of time or longer amount of time, but it has suicidality, your action should discontinue, right? So now, when it comes to children and teens, have you ever wondered why we don't have so many studies on kids and teens? Well, it's pretty simple, right? Because they have a reduced placebo response. So there are fewer experimental studies investigating the efficacy of antidepressants in children and adolescents when compared to adults, right? There are a lot more adults, and the adults can make their own decision. No parents want to involve a kid in the experimental studies, which means basically here that one of the kids is going to get the placebo, the other one is going to have the real medication, right? So parents don't usually want this to happen. They want the real deal, the real medication. So there are fewer studies for kids with uh, depressive symptoms. So there is a less evidence in children. Okay. Now, think about the medications that are often that have FDA approved for children, right? Think about Prozac. Prozac is the one that I believe is 6 and older, so it's is approved for children, FDA approved. So write it down, Prozac. So now, when you have a patient that has depression, you may want to ask, are you drinking to curb your depression, right? Something along those lines. I have put in a test on our PMHNP diagnostic test. Make sure you do it and you score above 85. So that will give you confidence for the real test. So why? Because alcohol use is often can be because of depression or can be the cause of depression. So you may want to see if the patient can't sleep, which is a signs and symptoms of depression. The patient is drinking to curb the depression, or is the depression being caused by alcohol? So asking the question about alcohol and if the patient is drinking because of alcohol may be important. So now again, antidepressants. Let's talk about SSRIs, SNRIs, TCA, MAOIs. So the board wants to know if you're safe. And how you show to be safe is by taking a safer route. And a safer route oftentimes is a longer route. When you are switching SSRI, SNRIs, TCAs, MAOIs, you want to wait 2 weeks. Okay. Why? Because you want to degenerate the medication. You want to excrete the medication. If the question says generate, you know that's incorrect. You want to degenerate. You want to take the medication out before you start another medication. There is an exception. Fluoxetine or Prozac. Prozac, you have to wait 5 to 6 weeks. Why? Well, Prozac has a longer half a life. Prozac has a longer half a life. You need to wait 5 to 6 weeks. Now, if you have MAOIs, two Prozac, again, is 2 weeks. So any medication, two Prozacs is 2 weeks. Prozac, two other medications, you have to wait 5 to 6. Now, Prozac can cause symptoms of insomnia, right? So your priority action is to either take the medication in the morning and do not need to prescribe insomnia medications. You may want to curb the Prozac a little bit, allow the patient to get used to the medication, but your action is not to prescribe a medication from insomnia, right? So if your options is to, if the stem of the question doesn't say the patient is taken in the morning, right, but it's taking Prozac, and one of the answers choices to give a medication for insomnia, and option B is medication given in the morning. So that's your action to take, right? Think of it is not disturbing the treatment, a safer option without compared to adding another medication for something that can easily be changed by giving the medication in the morning. Now, all medications, or most of the medications, have a half a life of about 5 half-lives. So what does it mean here, the washout period? So basically, it takes 5 half-life of however amount of time the half-life is, right, to get it into a steady state. A steady state is the state in which the medication is consumed by and then excreted, right? So it usually takes half, if the half-life is 50 hours, so it will take 5 times 5 to get into a steady state. Things that you have to watch out for when taking antidepressants are triptans. Anything that has triptans. Triptans are often used for migraine, right? But it can cause, especially if you give MAOIs, it can cause serotonin syndrome. So if the questions ask you to, you realize the patient is taking triptan and you realize that the patient is taking antidepressant, your action is to collaborate, right, to with the primary care provider. You want to collaborate. Remember, referring, we only try to refer in special occasions, when there's a specialized case, when there is a medical diagnosis, or when there's an OB patient. We try to, if possible, we try to refer. Like Rett syndrome, you refer. Autism, you may, you kind of, that's not a referral necessarily, but something that's specific, or cardiac problem, you want to refer. Heart failure, you want to refer, right? We don't want to take care of those conditions, but you want to preferably always find the solution, but you always can and should collaborate. If the answer choices are collaborating with OB, collaborating with PEDS, collaborate with neurology, that's something you want to do. You should consider the answer choice as one of the possible answer choice. You want to collaborate. Here, a prescriber indicating triptan for a patient that has migraine, and your action is to alert, to collaborate. Or you can choose your medication for something that doesn't have serotonin. Here in the case, the NDRIs. Okay. Another medication that can cause serotonin syndrome is sumatriptan. Again, the triptan, right? And the reason why SSRIs are the best alternative for antidepressant is not because it's the best efficiency. Efficiency, I'm saying compared to uh, de- depressed patients, right? Is because SSRI has something special about it. SSRIs, if the patient takes a whole bottle of SSRIs, they will feel sick, but most of the time they will not die. This is very different if they take a whole bottle of TCAs, which affects your heart. TCAs or MAOIs, they'll feel extremely sick and they may actually die. So SSRIs, the reason people prescribe SSRIs is because it is the safest against overdose. Okay, so the safe due to its potential uh, prevention of overdose, right? Now, again, guys, this is a very fast and short, right? So everything here is important. Now, since we talked about medications that can cause a lot of side effects, I want you to memorize and understand that escitalopram, Lexapro. Lexapro is a great medication. Why? Lexapro has one of the fewest uh, side effects, but one of the fewest drug-to-drug interaction. Lexapro has the fewest of the antidepressants. Uh, Drug interaction. So please write down this name, Lexapro. Now, when it comes picking a antidepressant and the patient has neuropathic pain, you can choose between SNRI or TCA or even alpha 2 delta ligand. So that's your pregabalin and gabapentin, right? So you have these three choices of medication: SNRIs, TCA, or alpha 2. Okay. So which one, if the three options are available, you pick the SNRI because they are safer than TCAs. Okay. Now know that all antidepressants can have this undesired sexual dysfunction. And then for that, you can add a little bit of a bupropion. When you do that, the patients often feel less depressed and they also feel more energized. So again, a patient comes to you and describe being depressed and low energy. What are you gonna give? Bupropion. Okay, well, Wellbutrin, bupropion. Now, what are the contraindications for patients with eating disorder and seizures? History of seizure, history of a TBI, anything that has hit the head, the baseball, hit to the head and had a TBI, you do not give Wellbutrin. So that's the contraindication for bupropion. Okay. Now, know that sometimes SSRIs in older adults can increase of anxiety and agitation. SSRIs in older adults can have an increase of anxiety and agitation. Now, more things to know about your SSRI, I mean your antidepressants. Avoid anti-acid medication or PPIs. And these are your omeprazole, your pantoprazole, right? Examples. Why? Because it can decrease psychotropic medication absorption. So, what is your priority? The ANCC love priority questions, right? So your priority is to educate the patient to wait 2 hours after taking a anti-acid before taking your psychotropic medications. Now, again, on paradoxical effect, we talked SSRIs can cause agitation and anxiety in older adults. When you hear paradoxical effect, think about benzodiazepine. That's a great one. They can cause a paradoxical effect, which means that rather than calming the patient, it may agitate the patient. So, your important point, if you come across questions that have a paradoxical uh, effect, is to avoid prescribing the same medication in the future, right? It seems simple, doesn't it? Understanding this concept may help you ace your test. So if you encounter paradoxical effect in older adults due to the SSRI, so don't give the SSRIs. If you encounter a paradoxical effect due to the benzo, don't give the benzo in the future. Now, citalopram has something special about it because it can cause a QT prolongation. So, recommended for adults no more than 40 milligrams daily. For older adults, for adults no more than 40 milligrams, and really should really keep at the 20 milligram day dose for older adults. Of course, if actions, maybe get an EKG because there is a QT prolongation, that's maybe a good answer too. Because when you're collecting or getting an EKG, you're collecting a assessment, you're assessing. Okay. Know that clomipramine also has the risk for a serotonin syndrome. Okay. So all your TCAs and MAOIs are high yield for serotonin syndrome. Now, what are the conditions that can cause suicidality? So, conditions that can increase suicidality, among them are schizophrenia patients, bipolar, depression, alcohol abuse, and eating disorder. Now, out of all these, your number one is schizophrenia. So, if you have to pick between one of these, schizophrenia is the one with the highest risk for suicidality. Now, if it comes to be a personality disorder, right, you need to understand that antisocial personality disorder is the highest risk for suicidal ideation. Bipolar patients, uh, not bipolar patients, I mean, patients with uh, other personality disorders, they may want to do self-harming behaviors, but they may not want to die. That's your borderline personality disorder. So higher risks for suicidal, homicidal ideations is your antisocial personality disorder. Out of the disorders with higher risk for suicidal behavior is schizophrenia number one. Schizophrenia. Understanding your positive and your negative symptoms are super important. So, when we say positive symptoms are those that add to normal behavior, including hallucination, that is your schizophrenia, or seeing, feeling, you're tasting, you're smelling, you're hearing things that are not there. Delusion, is part of your positive symptoms. Having strong beliefs that are not based on reality, like thinking that you are being persecuted or someone else is in love with you when there is no evidence of such behavior. Thought disorders usually or dysfunctional way of thinking, and movement disorders, agitated body movement. So these are your positive symptoms of schizophrenia. Now, if you think about the negative symptoms of schizophrenia, right, represent a lose or decrease in ability to initiate plans, speak, express emotions, or find pleasures. Right? So that's your anhedonia, decrease in ability to initiate or sustain planned activities. That can be a negative symptoms. Speech may be brief and need more content. Lack of pleasure, your anhedonia here, interest in life, or showing little emotions through facial expressions or voice tone, right? Now, kind of one way, if you find words that starts with the A, anhedonia, and many others, that usually is a negative symptoms of schizophrenia. Okay. Now you need to know age for schizophrenia. Why? Because you can use the age as a discriminator of possible schizophrenia. What I mean by that is that you may have someone that has the first breakthrough schizophrenia and the age is 45 and it comes through the ED. Well, 45 years old, Schizophrenia first breakthrough? That doesn't sound right. Could be, yeah, very little chance because we know that males are between age of 18 and 25, females 25 to 35. So if you see someone that goes through the MRI and what kind of change we may see, we may see a vascular enlargement, enlarged ventricle or ventricle enlargement. Okay, ventricle enlargements is what you may see in someone going through an MRI. You see ventricular enlargement. Anything else in the part of the brain would be decreased, but ventricular enlargement, okay, would be increased. Schizophrenia may exhibit changes or deficits in the prefrontal cortex. And we said that the prefrontal cortex is your ability to do as functions like planning, personality, right? They may also have a dysfunction in the medulla and basal ganglia, hippocampus, and the limbic system. Okay, this can lead to aggression, impulsivity, and problem with abstract thinking. So what are the regions of the brain that in which schizophrenia patients may have a change are the prefrontal cortex, the medulla, the basal ganglia, the hippocampus, and the limbic regions. This can lead to aggression, impulsivity, and problems with abstract thinking. Okay? Now, do not give a schizophrenia patient something that may increase dopamine, like a stimulant, right? Because a stimulant increases dopamine, and we know that schizophrenia, the positive symptoms of schizophrenia, is because of excess of dopamine in the limbic system. Okay, so avoid stimulants for patients with schizophrenia. Now, again, you may now want to give an alpha 2 adrenergic medications receptors like clonidine or guanfacine. Why? Because these medications have a limit neuroprotective effect. So those medications may not work as well as they would for other patients. So if you can avoid, yes, it would be better. Now, this medication may not offer a full benefit due to its low tolerability of patients with schizophrenia. One thing to watch out for is a sort of community treatment. And this is so important because you want to recommend a sort of community treatment for those patients that have a medication non-compliance issue. Okay, so what is the ACT? A sort of community treatment is or a treatment option that provides a 24 hours uh, service for those populations with bipolar, schizophrenia, or those that have medication compliance issues. It focuses on life skills, and the attempt here is to decrease the patient's readmissions to the hospital. So, for schizophrenia patients with high risk of medication relapse, you want to do a medical history and consider changing from a oral Haldol to a intramuscular Haldol depot. So you want to give less of the oral and switch it to something that has a longer term, right? And you want to do this by adjusting the dose. For example, some patients may be, let's say the initial dose for the first month is 20 milligrams multiplied by the daily dose with a maximum dose of 100 milligrams. Okay. So, whatever the patient has taken oral, let's say the patient is taking 5 milligrams oral BID. Okay. So, that's 10, right? 10 per day. You want to multiply that by 20 times the daily dose. So if it was 10, now multiplied by 20, so that's 200 milligrams. But the maximum dose is 100 milligrams per one injection. So you want to tell the patient to give first medication of 100 milligrams if you're going to switch from Haldol oral to intramuscular. So we get the daily dose, which was 10, multiplied by 20, they'll give you 200 milligrams. So now you want to give 100 milligrams up front and ask the patient to come back 5, 6, 7 days later to get the other 100 milligrams. But the maximum dose is 100 milligrams per injection. You need to know this. So you get the dose times 20. As long as it's not over 100 milligrams, the excess, whatever is over, you give the next time. So know the calculation of the oral dose times 20, not to exceed 100 milligrams. Now, MSC. Okay. Oftentimes we see MSCs and questions may ask you, where would you document delusions, right? Where would you document uh, uh, hallucination, things along those lines? So let's talk about the MSC for delusion. What is the delusion? It's a false belief despite evidence of the contrary. For example, someone might believe that their family member is part of a cult. That is an example of delusion. Okay. So it's a distinct between delusion and paranoia is important. So delusion is very different than paranoia. In paranoia, people feel that others are out to get them. So that's something to be said, that you need to distinguish between delusion, a false belief, and I give you example of the family member may believe that their family is part of a cult when there is no evidence of such. Paranoia, they feel that those are out to get them, is one example. Now, when we talked about the MSE for preschoolers, right? So we know that MSE usually is for adults. So in the preschoolers, you need to listen and observe cues. So your action is to listen, observe cues, and engage in clinical observation, right? Because they may not be able to give you abstract thinking. They may not be able to tell you all the answers that you need to know to complete an MSc. So for preschoolers, you listen, see, and feel. You engage in clinical observation rather than doing an MSc. So thought process and thought content. I kind of put this out so many times on the Facebook, and there is always someone gets that incorrect. So let's review thought process. You assess for the organization of the patient thoughts and idea, not the speech. You assess in thought process the organization of thoughts and ideas. Example includes, is it logical, coherent, goal oriented, or ones that are abnormal or asocial, right? So that's your thought process. Example of thought process, two of them, tangential and circumferential, are example of thought process. So tangential, it goes around, 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 and never gets to the point. Circumferential, it goes around, 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 eventually answer the question. So ask yourself, was the question answered? If it's yes, it's circumstantial. If it wasn't, then it's tangential thought process. Now, here is the golden question. Thought content is the patient thoughts and perceptual disturbance. Excuse me. So, where would you document suicidal ideation, homicidal ideation, visual hallucination, auditory hallucination? You document that in the thought content. You don't document this on HPI. You don't document this in safety. You don't document in any other place. Specifically, this is to be documented in the thought content. Okay, at least for the test. Okay, that's the appropriate place. So this information should be documented in the MSE. So if the question asks where would you document suicidal ideation, then you are to think MSE as one of the possible answers. But if the thought content is the also one of the possible answers, that's more specific. You want to pick the thought content. Okay. So or MSE or in the thought content portion of your assessment. Now let's move on to the MMSE, or also known as the Faustin scale. So you need to know that MMSE is the Faustin scales. What is it? It's a tool to qualify cognitive status in adults. MMSE is a tool to quantify cognitive status in adults, which is great because you want to quantify the patient this year. When it comes next year, you see the patient again. Hopefully it won't take that long, but you are able to say, hey, the MMSE, it was 20, now it's 15, so there is a decline. The MMSE higher number above 25 to 30 is considered normal. Below 25, depending of where what your number is, the lower number is bad or more likely to suggest a dementia, Alzheimer's of some type. Okay, you need to know where concentration, attention, and calculation is right. Now, one way to do that is by doing a series of seven, or subtracting 7 from 100 and asking the patient to tell you the number, 93, and so forth. Okay, so that is your concentration, attention, and calculation. Orientation, so is things like the year, date, season, locations, or floor where the patient is located. Okay. Registration, do not confuse registration with recall memory. Okay, so registration is assessing the ability to learn new material, and that's asked within 1 minute. For instance, say the name of three unrelated objects, asking the individual to repeat them after or within 1 minute. So registration is, are you able to tell me this is a cup? Obviously, it'll be three different objects. So if the patient say, hey, yes, this is, the cup, clock, or car, that's, let's say these are three objects that you mentioned, right? Within 1 minute, that means the patient is able to register. Okay, this is not recall. Now, when we look at the recall memory, so that's your immediate recall, you asking for the three objects after 5 minutes. That's your immediate recall. Okay, fund of knowledge is knowledge that everyone should know. One example of that is who is the president. Okay, so that's a fund of knowledge. So please know your MMSE, which is known as the Faustin scales. Understand how what it's used for. Understand the numbers from 30 to 0. Higher numbers are better, lower numbers are worse. Concentration, attention, calculation, you do a series of 7. Orientation, do not confuse registration with recall or immediate memory. Okay, and no fund of knowledge. There are more components, but again, we are just going to the fast review. Now we arrive to the clock drawing test. Okay, so why people do a clock drawing test? Well, it's simple because it screens for neurologic problems such as in patients with dementia. Okay, and it's very easy to do. It takes only 2 minutes or less. So it's a very valuable instrument in which can detect damage to the right parietal, to the parietal brain, or the portion of the lobe of the parietal that is damaged. So damage, if someone cannot do a clock drawing test, that means there is the right lobe or right hemisphere parietal there is damage. Remember, the Power 8 is about reading, writing. As I mentioned, you should be writing all this presentation on your own so that you do not miss any questions. So if the patient cannot draw a clock and put in the right numbers in the right place and everything that you ask, so there is a possibility to the right lobe or right hemisphere's damage, right? So, clock drawing tests, think about constructional aprasia, which is the inability to construct, assemble, or draw objects. So, that's the constructional aprasia. Okay. And when you see constructional aprasia or constructional aprasia, that's a damage to the parietal lobe. And that often can be seen with strokes, Alzheimer's, dementias of some type. So patients unable to do the clock drawing test correctly, that's the damage to the right lobe or right hemisphere, parietal. All right. So let's move on to the dopamine pathway, super high yield. Understand here test questions can be right, uh, right initiation of the question, followed by the incorrect. You always need to look at the entire question. If the entire question is correct, that could be the answer choice, right? And make sure that the answers are answering what the question is asking. So let's start by saying first generation versus second generation. The second generations are called atypical antipsychotics. What do they have that the first generation does not? Well, second generation are characterized by the serotonin receptor antagonism 5-HT2A. So the second generation antipsychotics or atypical, they have a 5-HT2A that the first generation does not. It is the hallmark of the second generation antipsychotics. All of them do. So, as such, acts as both as dopamine and serotonin antagonistic. So oftentimes you hear that the second generation are dopamine antagonists, and that's correct. But they also are serotonin antagonistic, less likely to cause EPS symptoms compared to the first generation. Okay, so second generation is better when we are referring to EPS symptoms because they are less likely to cause uh, EPS symptoms compared to the first generation. Okay, however, the initial psychotic breaks are often treated again with atypical medications that's what we want to do since we have a better medication compared to the first, and you do a intramuscular atypical medication. And now if we are talking about atypical intramuscular, I want you to write it down: Invega, Geodon, and Abilify. Invega, Geodon, or Abilify are good choices for uh, first breakthrough of schizophrenia with intramuscular application in Vega, Geodon, and Abilify. Remember, everything is important here. Now, what is super, super duper important, people often get this confused because they sort of know, but they don't know the details, the side effects, or the more intricate level. And the test makers will try to confuse you on the dopamine pathway, the super, super high yield. So, when we talked about the dopamine pathway, let's start by the mesolimbic. So, in a mesolimbic pathway, there is an increase in dopamine is associated with positive symptoms. We said the hallucination, delusion. That's your positive symptoms, and that's due to the dopamine increase in the mesolimbic pathway. As we move on to the mesocortical, here the problem is the decrease in dopamine in a dorsolateral prefront is linked to the negative and depressive symptoms of schizophrenia. So, if questions ask you, is it because of a decrease in serotonin? Yes. But the decrease in serotonin, right, it causes the negative symptom, but the answer choice is the decrease in dopamine in the dorsal prefrontal cortex is linked to the negative depressive symptoms of schizophrenia. As we move on to the nigrostriatal, I want you to think motor movement. Here it gets interesting because when you have a blockade of dopamine here, right, there is a increase in acetylcholine level. So you have less dopamine, acetylcholine goes up, right? When you have acetylcholine levels that are increased, you need to know the symptoms: salivation, teary eyes, and diarrhea. So everything is kind of wet here, right? Because of an increase in acetylcholine. So, what are the EPS symptoms from the blockade of dopamine? So, the EPS symptoms, we are talking about acute dystonia, which is manifested by painful neck spasm, right? It can cause Parkinsonian like symptoms and akathisia, right? Not exclusive to antipsychotic medication. So I'm putting here Ralligan, right? It may seem out of place, but it's not because Ralligan can cause EPS symptoms. You need to write it down. May cause EPS symptoms like TD, tardive dyskinesia, and dystonia, really. So individuals taking both antipsychotic medication and Ralligan are in particular at risk, right? So what you want to do is for acute dystonia, Parkinsonian, and akathisia, what you want to do for dystonia, Parkinsonian, and akathisia is use benzotropine, or better known as cogentin, a anticholinergic, right? Because we said that dopamine decreases cause a increase in cholinergic or increase in the acetylcholine. So we're giving a anticholinergic. Gee, that makes sense, doesn't it? So we're gonna give an anticholinergic here. And for the three symptoms that I mentioned, dystonia, parkinsonia, and akathisia, are we going to give anticholinergic for tardive dyskinesia? Are we going to give that? No, 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 no. So what are we going to do here? For this tardive dyskinesia, we are not going to give benzotropine or cogentin. We want to give them by managing the TD involves the reducing the dose, switching the dose to a preferably atypical antipsychotic. Okay. So let's do an application question. Which side effects are seen in patients presenting with EPS related to nigrostriatal dopamine blockade through the antipsychotics medication? Think of it. What are the signs symptoms of EPS that we just mentioned? The side effects include acute dystonia, parkinsonia, and akathisia. Treatment, cogentin, okay, which is anticholinergic medication. Additional increase in acetylcholine can cause salivation, teary eyes, and diarrhea. Now, be on a watch out that questions may pose as: is this due to the blockade of dopamine, or is it due to increase in acetylcholine? Now we kind of get me, right? Is it one or the other? Really, it's both, but the symptoms is caused by an increase in acetylcholine. Well, yeah, it was caused because before there was a decrease in dopamine that caused the increase in acetylcholine. So read the question really attentive, okay? Now we finally get to the last pathway, which is a tubular fundibular pathway, and the blockade again here in this pathway. In the nigrostriatal, you blockade the dopamine, you have an increase in acetylcholine. In the tubulofundibular pathway, now you have a blockade in dopamine and you have prolactin. Prolactin is the cause of the symptoms. You have an increase in prolactin when you blockade the dopamine. So a higher prolactin level can cause what? Amenorrhea, galactorrhea, right? Also, a medication that's very known to cause galactorrhea is risperidone. Write it down. risperidone, you can have sexual dysfunction and gynecomastia. Long-term increase of prolactin due to the decrease in dopamine can cause osteoporosis. So, tuberofundibular, you have amenorrhea, galactorrhea, sexual dysfunction, and gynecomastia, and osteoporosis as a possible side effect. Okay. All right, guys. So this one is about over. This is our part two. The next video I called part two, but really is part three. I wasn't counting the introduction, the strategies. I hope you enjoyed. Most importantly, I hope you wrote every single thing down because every single thing is so important. I'll see you on our next video. Bye bye.